Hello everyone, welcome to YouTube live session for a very important topic, cytomegalovirus infection in pregnancy. So here's me, Dr. Bhavna Khera. So I'm here to talk about this very important topic, and we are going to cover this topic from two very much updated articles, I would say. One is scientific impact paper, which came in 2024, and the another one is a recent talk article from 2025 July session, which is about this as well. So this is a very favorite topic. It has always been a RCOG's favorite topic, and with all the recent updates, it makes it further more important. And we should know the intricacies about it. But while talking about the CMV, I'll still remember our tagline: ensure success in 70% less study time. So definitely, we are also going to read these two things, like one SIP and one talk article in 70% less study time. So I would like to know, if you have to read this article for the first time, one talk article and one scientific impact paper, how much time you would have taken to learn that, right? Read, make a summary, and then retain it. How much time would you quote? Let me check answers in the chat. How much time do you think you will take if you have to read this talk article and a scientific impact paper yourself? Just let me know before I start the session, because then we'll see whether we are really decreasing the time by 70% or not. So that's what I'm basically wanting to look at. So please help me with that. Can you quote a figure in the chat box? What how many hours you can think about if you have to read one talk article and one scientific impact paper? Okay. So meanwhile, I'll start the session and definitely would be looking for the answer in the chat box. As soon as I get few answers, then in the end we'll talk about, yes, we were able to decrease the study time or not. So let's start the today's session. So yes, very good evening, Dr. Swati, Dr. Mitu. Yes, very good evening. Nice to see you all here, Dr. Gayatri. Yes, very good. Do definitely answer my question. Like, if you have to read a talk article in SIP, how much time you would take? 4 hours, 2 hours. Other, I would rather like to listen to you. Definitely, I'm going to talk about it, but just wanted to see. Yes. So we are sticking to our tagline or not? Okay. So very good evening, Dr. Beena. Yes. Okay. Okay, let's start. So we are going to talk about this very important topic, and this is important for part one, part two, and part three, all the batches. For part one, serology will be important, like how to interpret the serology. Till now, always you get the hepatitis B serology, syphilis serology, but this time CMV serology can be a hot topic. And for part two also, the serology as well as the management part becomes very important for part two. And part three, you can have a full station, because CMV station has previously appeared in exam as well. So you can have a full station about the CMV. So it's important for all, part one, part two, and part three. So here we go. So this is congenital CMV key facts for the exam. So most common infectious cause of neurodevelopmental impairment in developed countries, and a clinical presentation at birth. Remember, our CMV loves 10. Most of the things are going to be revolving around 10. So it's not difficult to remember the numbers. Keep 10 for CMV, okay? So symptomatic, 10% are only symptomatic at birth. They are petechiae, there are microcephaly, seizures are there. Then there is deafness and chorioretinitis. So sensory neural and hearing loss is there basically. And this is one of the most common cause of that. Mortality, 5% of the symptomatic cases, the mortality is there. There is severe infection and these babies may die. 10 to 20%. Coming back to our 10%, we'll remember our 10% figure. 10% of neonates with the hearing loss have congenital CMV. This we are going opposite, right? Previously, we were saying that 10% are symptomatic. Okay, now we are saying that all the babies who are born with the sensory neural hearing loss, 10% are because of the CMV, right? Similarly, all the cerebral palsy kids, if we see, then again 10%. It is 5 to 15. So you can remember the middle finger, that is 10. So 10% will have the cerebral palsy. 10% of the cerebral palsy kids are because of the CMV infection only. So sticking to 10, nothing extra. Now, what about the virus and the transmission? So there are two types of virus. So yes, good evening, good evening. So there are two types of transmissions. Either it is a primary infection or it's a non-primary infection. Not transmission, it's the infection. One way the patient may have new infection in pregnancy, so that's a primary infection. Non-primary, she already had, then it is reactivated. Because the virus that has a very long latency. As with other viral diseases, the same is with the CMV as well, where the lifelong latency is there and it can get reactivated any time later. So reactivation or the reinfection can occur. And we do not have any vaccine for that, right? So that kind of a risk always remain there. But usually it is only there when the situation is immunocompromised and pregnancy being one of the scenarios. So primary CMV infection can occur at any age. Only 7% adults, they just have fever, arthralgia, myalgia, sometimes some lymphadenopathy, which is not easily recognized. And it is generally taken only as a fever, as a flu, as a viral flu. So we do not investigate these patients. So viremia, then that occurs and then it declines. And usually it take almost 1 month to become the undetectable in a immunocompetent adults. Immunosuppressive ones can have a prolonged this kind of prolonged shedding can be there, so it can take much time to come back to normal. But yes, in immunocompetent adults, only 1 month of shedding is there. So viral shedding, healthy seropositive children shed CMP for more than 3 months. Now, this is the problem. So usually the adults are not getting the infection from the outside like that. It is basically when they come to in contact with the children who have got the infection. That is why the multiparous women are at more risk of getting infections as compared to primary gravida. Because they have their own kids, they will be catering to them, they will be very close to them, so they are more likely to get the infections. So more the isolation, the more the hygiene measures are practiced, the less is the chances of infection. So increased risk is in the child care workers and mothers with the young children. So that's what I talked about, the multiparous women and the increased risk in the child care workers, because they are also working with the children. So in the school nursery teachers, or those people who are working with the kids, they are more at risk of this. So this is basically about the virus and the transmission. And of course, there is a transplacental spread which occurs. So therefore, there is a risk of the fetal congenital infection as well. And later on with the contact also, this is there with the secretions. So it is post delivery also the chances of infection are there. So either way, both are there. So we can have a neonatal infection and we can have a later on the from the secretions as well. So now vertical transmission. We are bothered about this, right? Patient is pregnant. So we are very much bothered about the vertical transmission, that is which is occurring through the placenta. So occurs in the primary infection, deactivation or reinfection. So does not make a difference whether it is a primary, that is the first infection, or any infection which was previously present and now it got reactivated. So reactivation, reinfection, primary infection does not make a difference. Risk is 4 times higher in the primary infection. But yes, risk is higher in the primary infection, but it can occur with the primary as well as non-primary, right? This is very important. Now, what is the transmission rate? Very favorite figures of RCOG. What is the transmission rate? So, as we go towards the end, the rate of transmission increases, but severity is there in the first trimester. Okay. So the rate of transmission is definitely increasing from first trimester to third trimester, but severity is more in the first trimester. Okay, so this is the rule. Just remember that. So first trimester is 25, 45, and can go up to 75. So remember as 25 to 45, then remember 45, and then remember 75. So this is how the risk increases. And early periconception first trimester transmission will lead to severe congenital infections. That is the placental insufficiency risk is there. So that is how we have to remember. Now coming on to diagnosis. How to diagnose? I told you that we do not do routine screening, and the mother herself has only flu-like illness. So not usually we do not go for the testing because that is just taken as any simple viral fever. So now if we have to go for this maternal diagnosis, what we have to do? So if there is anything like it seems like the mother has got a flu, or mostly we go retrospectively, like if when you see any features of the ultrasound and then we go and do that testing. So that only triggers the testing because testing is not routine. Universal screening for CMV is not recommended by RCOG. So in this case, when we do the testing, what investigations we are going to do? So first we do IgG and IgM, right? So first we do IgG and IgM. So these are the two which are done. So IgG definitely, as the rule says, IgG is the past infection and IgM is the recent primary infection. Now it is not that simple in CMV, which I'll just take you in the further charts and show you why it is so different from this IgG, IgM, which we routinely study in all infections. It is not that simple in the CMV. Then there is another term which we use here is the IgG avidity. So IgG avidity is the capacity of the antibodies to bind with the antigen, right? So that basically identifies the capacity of antibodies to bind with the antigens, IgG antibodies to bind with the antigens. So low capacity of binding. That means they are fresh, just born. So they don't have that much capacity. So less than 3 months. This indicates recent infection. Okay, this indicates recent infection because low avidity means less capacity of binding. Less capacity of binding, they are fresh, they are babies, they are just appeared. So there is less capacity. So infection is recent. When it is high avidity, oh my God, they have grown up, they have got a good avidity. So now this is infection more than 3 months. Okay, infection more than 3 months. So this is slightly prior to 3 months. I don't say old infection, not years back, but it is basically the more than 3 months back. What is the significance? I'm just going to talk in the next slides. Why we are taking this ad like this. Maternal PCR is not reliable for timing infection. So if you want to take any secretions, fluids, and you want to do the PCR, like you want to take blood, saliva, urine, it's not work. It does not work. It is not the correct test, and it cannot, the serology cannot diagnose reactivation. Now serology cannot tell you with this low avidity, right? If the patient has a low avidity, now whether it is a new infection or it's the previous infection which reactivated, right? We cannot tell this from the serology. So from serology we can just tell that whether the patient has any recent infection which is active or not. This we can come to know. Okay, is this fine? Any questions? If you have any questions, you can leave them in the chat box and I will be happy to answer those. Okay, so now coming to this interpretation of this. Once you have done the IgG, IgM, what do you expect? So what do you expect is basically, as you see here, IgG negative and IgM negative. Both of them are negative. Patient is non-immunized. That's what it means. Patient does not have an infection, but that patient is non-immunized. Now, if the IgG is positive and IgM is negative, so IgG is positive, it always means the past infection. Patient is already immunized because of past infection. Vaccine is not there. So this immunity cannot develop from the vaccine. There is no vaccine. So if it is basically the past infection which is leading to this. Now, IgG positive, IgM positive with low avidity. So now IgG positive, IgM positive with low avidity. So there is very recent infection less than 12 weeks ago. We just talked about low avidity, recent infection less than 3 months. So less than 12 weeks. If it is IgG positive, IgM positive with high avidity, recent infection with more than 12 weeks ago, or it's a reactivation of the old infection, right? So this is how we interpret this cytology. I hope this is clear till now. Any questions? You can leave in the chat box. I think this is clear. Now, there is another scenario where you can have IgG negative, but M is positive. IgG is negative, but M is positive, right? What does this mean? Do it means that it's a recent infection? Because usually it is so. When IgG is negative and IgM is positive, we usually say that this is a recent infection. That is why antibody has not developed. But this is different, right? In CMV, this does not hold true. If this is there, that means there is a cross reactivity. So maybe any other viral infection is there, like one of the example can be Epstein-Barr virus, which is causing this and not the CMV. So how do we confirm this? We do this repeat testing after 4 weeks. If it is still the same, then definitely it is the other infection. So only IgM positive for CMV does not carry any significance. It is usually because of false positive due to cross-reactivity with other viral antigens, right? Any questions till now? All good? Okay. So we know what are the probabilities we can have with IgG and IgM. For part 1 students, this table is the most important table. Please remember this with heart. Now, what is the antenatal advice for the patients? Okay. Routine antenatal advice for primary prevention. So basically, we cannot do anything, right? There is no vaccine. There is no routine testing, no routine screening is done. Only we have to advise to use the hygiene measures. So women should be informed about the risk of infections in pregnancy in the first antenatal appointment, including advice on hygiene precautions to prevent infection. Infection precautions include good hand hygiene, hand washing before and after changing the infant's nappies, not sharing foods, cups, or cutlery, and avoidance of close or orofacial contact with young or ill children. So there are three things. Do not share. I mean, sharing should be with some care, right? Sharing should happen with some care because if you are sharing everything using the utensils and the patient is pregnant, that's a red flag. So be very careful. So share with care. If you can remember that dictum, that's fine. Now coming to how to make diagnosis and how to interpret and what are the next steps in the management. What kind of a serology will be there and what will be the next steps? We have to follow that. So basically, we are dividing this into two groups. One group is less than 24 weeks and another is more than 24 weeks. Okay. Now coming to less than 24 weeks, what we are doing in these group of women. So, okay. Uh, Immediately, ma'am, instead of repeating after 4, can't we do testing for other infections like EBV immediately instead of repeating after 4 weeks? Okay. So basically, that kind of a viral testing, routine viral testing for all the viruses is not recommended. And they are all specialized tests done only when the symptoms of that particular condition are there, not done routinely. Okay. And secondly, not all viruses will produce problems in the baby. So we are bothered about the viruses which are causing effect in the baby. So currently we are looking to for the if the CMV is there, because any other viral illness which is not affecting the baby, if at all is there, is not making a difference, right? And secondly, this 4 weeks gap is not going to basically create any loss to patient, because otherwise also the effect which will come in the ultrasound, you will be seeing it after the 4 to 6 or 7, 8 weeks. So you will not immediately see the effect of the CMV in the baby as well, right? So therefore, it is not very much feasible, or not a feasible and not a honest decision or the valid decision to do the testing for Epstein-Barr virus at that point of time. I hope I clarified your answer. Question, right? Okay, so coming to this, less than 24 weeks and more than 24 weeks. Why we have divided like this, right? Because this is the cutoff. After that, the infection rate, the severity decreases. Drugs are more effective in the first trimester in reducing the vertical transmission. So this category behaves differently, and the other part is different. Now here, less than 24 weeks gestation maternal serology, we do index sample. What do we mean by index sample? That is, we want to test this patient at that particular time. Either she has the signs or symptoms, or you have find some kind of a thing is there, some trigger is there which is saying that patient needs to be tested, and it is mostly the symptoms of the patient only. So now, if it is both negative, IgM and IgG negative, I told you CMV is ruled out, right? No risk of uh, CMV is totally ruled out. But it can occur later. It can seroconvert later. So we will do one more testing at 4 weeks. And if it is still negative, it's done. Now coming to another scenario where I told you that IgM is positive and IgG is negative. Okay. IgM is positive and IgG is negative. So I just told you in the last slide, this is nothing. This is nothing for CMV. We'll just repeat one more time in 4 weeks. If it is still negative, it is just simple cross reactivity, right? So this one is easy. This one is easy, right? Now coming to the other two. IgM is negative and IgG is positive. So patient is immunized. So you can just reassure the patient and that's fine. So now this category is also fine. Now coming to only this category. IgM positive and IgG positive. So retrospective serology on the booking sample. Now we go and see the booking blood sample, right? And compare it with that. We always have to compare. In CMV, one sample does not indicate any much thing. You have to compare it from the previous one. So now we go and see the booking sample with this patient. If the booking sample was negative, right? And now it has become positive. So that means patient has now got the CMV infection because the seroconversion has occurred. Now, other is you see that they both were positive at that time also. Okay. Both were positive at the booking also. So in those spaces, you have to check the avidity. So once the avidity you check, if it is low avidity, that means yes, it's within 3 months. And because you are looking at the early part of the patient, so within 3 months means infection in the pregnancy. So yes, patient has got the infection. Now, if it is a high avidity, then it is usually the long time back. So maybe preconception is there. So we are not bothered about this. Okay. So these are the two categories we are bothered here, where either previously it was negative, now it has become positive, or previously also it was positive, but now it is low avidity IgG. So we are bothered about these two categories, right? So this is how we have to interpret the serology. I hope this is easy. Any confusions? Just remember it once so that you don't forget. Okay. And now what will happen? So if it is, I told you, if it is a preconception, then we don't have to do anything because that is old, right? So only reassurance. But we will do neonatal PCR when the baby is born. Neonatal PCR when the baby is born within 3 weeks from the birth. We'll do one testing just to see if any effect is there. Booking sample means the one which you, when you took the sample at the time of booking bloods. Okay, that's it. So, low avidity increases the risk of transmission. Yes, because it's the recent one. Okay, now coming to the post-conception and peri-conception, we are bothered about these. Now, these are the patients which will require the treatment. So the drug of choice is valacyclovir, which is given 8 grams per day. Usually it is 2 grams in 4 divided doses, and this will reduce the risk of vertical transmission by 71%. So this will reduce the risk of vertical transmission by 71%. So valacyclovir is the drug of choice for these patients. Now you are giving this drug to decrease the chances of transmission to the baby. Now, because it is 71%, it is not 100%, we have to check the baby. So when to check? Amniocentesis is done 21 to 22 weeks for CMV PCR. Now, why it is 21 to 22 weeks? Why we are not doing early? Because the virus in the amniotic fluid will come from urine. And it's the 17, 18 weeks when the urine contributes the maximum part of the amniotic fluid. So basically, at 18 weeks onwards, you can detect the virus in the amniotic fluid. So therefore, it is done usually at 21 to 22 weeks. Now, if it is negative, no issue. Baby is safe. Now you can stop the valacyclovir and you can do one test later in the neonate within first 3 weeks from the birth. But if it is positive, we will move on to the next flow chart. Okay. So in two cases where the seroconversion was positive or where the low avidity was there, we started the treatment with valacyclovir at the dose of 8 grams per day and we continued this treatment till we do amniocentesis. Amniocentesis is usually done at 21 to 22 weeks, at least beyond 18 weeks. So, and that time, if it is negative, patient is fine. No need to go for the drug. Stop the valacyclovir and offer the neonatal testing within 3 weeks of the birth. And if it is positive, then let's see what would be the next step here. Positive, of course, the baby is infective. So we will have to see when the baby is infective, then what we have to do for that baby. Okay, all good till now? We do sero testing at the time of booking in all pregnant women. No, see, this is not required, but the samples of the serum are there that are saved, and from there you can actually check. Okay, so that is there. Now, this is maternal primary CMV infection diagnosis. Now, when do we say that there is CMV infection? So, I've already told you the same thing, that the seroconversion, we look at the seroconversion. We have just read this. IgG negative to IgG positive, or there is low avidity. Valacyclovir is given and it decreases the vertical transmission risk by 71%. Amniocentesis is done at 21 to 22 weeks and it is stopped if the amniocentesis is negative. Highest efficacy of the drug is in the first trimester infection. So if you give this drug in first trimester, this maximum reduction is there. What are the side effects? Nausea and headache is common side effects, and 1.7% risk of acute renal failure resolves after stopping drug. So you have to monitor the maternal renal function. Otherwise, it does not have any side effects in the baby. So very safe for the baby also. So this is a bit about the drug and its usage for the infection. Now coming to more than 24 weeks. Now what to do? So in more than 24 weeks, depending on the serology, again, we'll go by the same things. So basically, if both are negative, nothing. Just reassure the patient and if any new exposure is there, then you will repeat the serology in 3 to 4 weeks and nothing else. If IgM is positive, again the same thing. It is a false, right? IgM positive, IgG negative is false. If IgM is negative and IgG is positive, then usually it is the old one, right? Old one. If it is the same which is there, so usually it is the old infection. We don't have to do anything. Again, in this case, we are bothered about this category, which is both positive. So that is one thing which is bothering me again. That is IgG and IgM. That is both positive. So now what happens in this? Now, in this case, again, we have to go back and look at the booking sample. What is the change? So again, when the high avidity is there, we will reassure and later on offer the neonatal one, the same thing which we are going to do. Now, otherwise, if it is a seroconversion, like previously it was negative, or now it has become positive, or the low avidity IgG is there, then we will do the fetal medicine referral for targeted ultrasound, right? Fetal medicine referral for targeted ultrasound, because this is the scan where we will have to check for, it is a targeted ultrasound to see the any abnormal features for the CMV infection. Here in this category also, like whenever the patient has IgG positive also, either they are immune, we'll tell them that they are already immunized, but we still do an ultrasound, right? Because it's a non-invasive test, so we can do that. If the ultrasound comes to be normal, so just keep on doing every 4 weekly ultrasound, and later on you can offer the neonatal testing and finished, right? Now the problem comes when the ultrasound shows the features. Now this is the patient which requires a proper counseling, because abnormal ultrasound, even if with serology negative, makes a difference, right? So abnormal ultrasound, even if serology negative, then also it is important and should be considered. So now this is the problem where from here the problem starts. So abnormal ultrasound, so what you all can find here is the severe growth restriction, microcephaly, or some liver calcifications can be there. So these things you will look for in the abnormal ultrasound. Now, maternal serology, you have to look at the maternal serology. If it was negative, then CMV is excluded. There could be other causes of SGA as well in these patients. If the patient has the IgG positive, irrespective of IgM negative or positive, then this patient is a high risk for the congenital CMV. And these are the patients who will go for the amniocentesis. Now, in amniocentesis, you can take care of both the things. You can do chromosomal testing as well as the CMV PCR testing, right? So, both of these things can be done for these patients. And you can rule out whether this severe growth restriction is because of the if because of the genetic problems or it is because of the CMV infection. Now, once you detect in amniocentesis that there is a infection, then what? Then how to proceed further? Now it's about the management of the fetus and the neonate. So in the fetus, if it is detailed fetal ultrasound, you have to do every 2 to 4 weeks, and fetal brain MRI is done at 28 to 32 weeks. So this is very specific. How do we follow up? Part 2 students, this is very important, and for part 3 students, how do we follow up the positive amniocentesis test? We do serial ultrasounds every 2 to 4 weeks, and MRI is done at 28 to 32 weeks. Now, if the patient asymptomatic, there is nothing there, ultrasound is fine, nothing, just keep on monitoring, repeat ultrasound every 2 to 4 weeks, and repeat one more MRI for the brain after 3 to 4 weeks. All good? Wait till the delivery, deliver the baby, and do the neonatal testing. Nothing much. Now, if the mild to moderate symptoms, mild to moderate symptomatic fetus. Now, what is this? One kind of abnormality is there, either in the brain, either in the liver, mostly in the liver. Brain will be still serious, but the liver, so one organ only affected. So mild to moderate symptomatic fetus. So now in this case, either patient can go for termination of pregnancy, right? This is mild to moderate symptomatic fetus. So either the patient can go for termination of pregnancy, that's a patient choice, right? Or she can be given a drug treatment with the valacyclovir in this case. Okay. So she can be treated with the valacyclovir in this case. And then she keeps on monitoring. And then with the neonate, we will be treating again. Now, this particular termination of pregnancy is a patient's choice, right? Baby is not severely affected, but that's a patient choice. So this will be under the abortion clause C, right? So ground C, abortion clause C will be there. This is an important question for part 2 students. So this is the abortion clause C, because patient is choosing this by her choice. But when there is a severely symptomatic fetus, then patient is usually offered termination of pregnancy. Severely symptomatic fetus, more than one organ affected. So offer termination of pregnancy. Now in this case, severely symptomatic fetus, because baby is abnormal, so you are opting for termination. So now it is ground E. Okay. So now this is abortion clause E. So in abortion clause E, there will be no time limit. Patient can have termination anytime in the pregnancy, while C, patient can have termination only up to 24 weeks, right? So this is how your grounds will be different for these two patients. So once you are going with the monitoring, then you will just keep on monitoring, and then you once you deliver the baby, then neonatal care will start. Okay. Neonatal care will start and you will do the placental examination as well. So what is about the delivery? Delivery as such for CMV has no rules. It will just follow whether the patient is fine or a baby is fine or not. So if it is normal growth Doppler, no change in timing. FGR is present, then you will follow the rules of your FGR guideline. Mode of birth, no need for C-section. You can go for the vaginal delivery. Intrapartum care, there is no such special thing, but only thing because the amniotic fluid has the virus. So any pregnant staff should not attend the patient. It is not a rule, but that is something we should do on a humanitarian grounds. What about the neonatal management and outcomes? Prevalence is 1 in 200 live births in high income countries. 50% are due to non-primary infection. So I already told you, it is not only the primary, but non-primary also can give this. Going back to our 10% rule, 10% symptomatic, 5% mortality is there, and 20 to 30% will have long-term neurodevelopmental impairment. So we require a multidisciplinary team follow-up. That is, neonatologist will be involved, infectious disease specialist will be involved, ophthalmologist will be involved, audiologist will be involved. An important point for our part 3 students. Multidisciplinary team, neonatologist, infectious diseases, ophthalmology, and the audiology. Now, breastfeeding is safe and recommended for affected infants. For 6 months, term neonates infected postnatally, asymptomatic, no neurological sequelae are there. And preterm or very low birth weight infants can up to 20% contract postnatal CMV and may develop sepsis or long-term issues, right? So that's there, but otherwise breastfeeding is completely safe. Now, what is the counseling regarding the recurrence risk? So very low risk of reinfection and vertical transmission is there. So patient is almost safe. How much time she has to wait? At least 1 year. She should wait for 1 year to again conceive, because viral shedding can continue for months. Okay. But and none of the serology testing, no testing can decide when she can become pregnant. So therefore she can become pregnant usually after 1 year. If there is any specific immunosuppressed case like renal transplant patients on immunosuppressants, then you have to make an individualized plan as per the fetal medicine specialist. And of course, you always have to provide the link of charities and the support groups for our part 3 students. And the most important is hand hygiene. Avoid orofacial contact with the young ill children. That is what the antenatal advice still stands true. Yes, that was about the guidelines. So I think that was more of a 30-minute session. So yes, a few of you have answered like 4 hours, 6 hours, 5 hours for reading the guideline. So we have finished in 30, 35 minutes. So I think we still hold true with the 70% less study time. So that's it. Thank you so much for reconfirming it once again. Fine. So any questions from your side before I put up 2 questions to see how much you have all have understood the session? Any questions? Anything you want me to clarify? I'll be happy to repeat again. I think that should be fine. Majorly, you have to go with the serology, IgG, IgM, and avidity. These are the 3 main things. Various combinations, right? If it is IgG positive, largely it is immunized. If both of them are negative, we are not bothered. If only IgM is positive, then it is largely because of the the cross reactivity is there. We are most bothered about the group where IgG and IgM both are positive. And in that case, we have to look for avidity. Low avidity, the recent infection, we are more bothered. High avidity, old infection, we are not bothered. And whenever we are bothered about the infection, we will do this for whenever there is a risk of infection, we will do scans, serial scans. Amniocentesis is done actually. In amniocentesis, if it is positive or negative, accordingly we will manage. Serial growth scans are done, and simultaneously MRI brain is done if the amniocentesis is positive. So that was just a gross thing to tell. And valacyclovir can be used for the patients who have a risk of transmission, so we can give that. And for the neonates, what is the drug of the choice? So that is valganciclovir. We treat neonates with the valganciclovir drug. Okay. Are you conducting any live mock or remote mock for part 3 students? Yes, we'll be conducting part 3 students. You can get in touch with me on the website address, on the email or my phone number, which is mentioned lower down in the slides. In this particular slide, it is, I think, not very much visible, but yes, here it is. You can take the screenshot and we can connect over the call, or you can mail us to get the details, or I'll leave the details in this in comment section. Okay, so let's talk about the question first. So 29-year-old primary gravida at 21 weeks gestation at a routine antenatal clinic appointment recalls having a flu-like illness approximately 3 months ago. Now this is a 21 weeks patient. Which of the following serological findings would indicate a primary CMV infection that likely occurred recently, suggesting a high risk of congenital infection in her current pregnancy? So which of the following goes in favor of the recent infection? Oh my God, it's too fast. Yes, very good. So two answers I've got, and I'm looking for more answers. Everybody, please try to do that. We are looking for a primary CMV infection. So what did we say? What two scenarios can lead to primary infection? One is seroconversion, that previously IgG-IgM was negative and now it has become positive, or IgG-IgM is positive and there is a low avidity IgG. So now D is the correct answer. Yes, very good. And who has answered first? Dr. Santoshini. Yes. So the 3 cheers for her. And she's the first one to answer. Definitely, I can get many answers. That's fine. So thank you so much for being so active and answering. So negative IgG and negative IgM, of course, no infection. Positive IgG and negative IgM, that's the old infection. Positive IgG and positive IgM with high IgG avidity is also old infection, more than 3 weeks. Then 3 months. Positive IgG, positive IgM, and low IgG avidity is the recent infection, and that's what we are looking for here. Okay, this is the last and the second question. 32-year-old primary gravida at 26 weeks gestation has recently been diagnosed with a primary cytomegalovirus infection. Fetal infection has been confirmed by amniocentesis. Now, here the infection has been confirmed by amniocentesis. Now, what to do? Which of the following is the most appropriate next step in management of the patient? So, do we administer the single dose of CMV hyperimmune globulin to the mother, or we advise immediate delivery to prevent further viral transmission, arrange for serial detailed fetal ultrasounds, initiate a course of intravenous ganciclovir for the mother, and recommend termination of pregnancy due to confirmed fetal infection? So what we do? Patient is 26 weeks. So what we will do for this patient? Yes, looking for answers. Let's see who answers first. Yes, 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 correct. So C is the correct answer. We will do the ultrasound. Termination we only recommend when the baby is seriously affected, right? In that case, only we do this. So Dr. Komal Jasuja, claps for you. You were the first one to answer. So yes, correct. Everybody is but answering correct, and I'm so happy that now you remember this topic very well. So that's how You can have a fun learning with us. If you are not still in our group and not yet joined MRCOG courses, then you are missing on fun in studies. So please do so. And definitely we help you prepare in 70% less study time. So CMV hyperimmune globulin, not a care. Immediate delivery not required. Serial ultrasound is the correct step. IV ganciclovir is not recommended and recommend termination is not automatic, only after counseling if severe anomalies are detected. So that's it. And I think there are the numbers, our website, and our email address. Those who want to be with us, you are welcome. Yes, we have part one, two, and three courses. And yes, definitely. I'll be happy to help you out. So basically, the your path to success, our three-step system. That is, first we define the syllabus. So you have a very limited content in the course, not a long guidelines or not everything to read. Rather, with us, you don't have to go and touch the guidelines even. Just stick to the content on the website. No books, no guidelines. Just stick to the content on the website. Practice, refine, revise, and retain. That is how we just do. So R, keep on repeating until you will succeed in one go, right? So that's it. So only course with the unlimited access, you can do prepare at your own pace. Whenever you feel confident, then you can apply. We don't charge again. There's a one-time payment, and you can keep on reading till the time you want to read. So you have seen the new structure. You know it saves your time. You know it works. So you are ready to pass smarter. Just you need to scan the code and join. Let's hear from you. Question and answers. Drop your questions in the chat and I'll be happy to answer for you. So this is a hug for you. Thank you so much for joining and being so active in the session. That motivates me as well to bring on new topics. Any new topics you want from my side, just let me know. So let's say it together. You don't need more hours, you need more clarity. And let this be your last attempt. We are here to help you pass with confidence. Thank you. Thank you, Dr. Swati. Thank you, Dr. Meetu. Thank you, Dr. Beena. Informative session. Wonderful session. Thank you so much for always being there and trusting the MRCOG courses. Attention community, this is an important message. So if you are planning this to be a last time, then we are here to support you. Thank you. And we will meet again in the next session in our next YouTube live. Okay, any particular topics you want to be covered, please leave that in the comment section. I'll be happy to take those. Bye bye. Have a nice day ahead. Yeah, yes. Thank you so much for such a simple roadmap for CMV. Yes, I know this is a very, confusing topic and avidity and all this, but probably, yes, it was simple and you will remember, right? It's more about retention. Reading is possible, but retention is important. So when the reading is accompanied by retention, that brings success. Okay, bye bye. Take care. Thank you, Dr.